Hi, it's a great pleasure to talk here on genetic disorders commonly seen in Asians at this August meeting of Asia Oceanic and Parkinson Disease Movement Disorders Congress here in Kolkata. All my talk, if I need to tell, all started off because of this person, that is Professor Gregor Mendel. As we all know, Mendel is the founder science on genetics. And not only that, he is the one who gave us an idea about how genes transfer from one generation to another generation and how based upon this some become prominent or some become recessive and why certain type of patterns are seen in different generations. This opened up whole concepts of understanding of genetic based disorders. And then when we started to go forward, we started to look into human genetics as a pool. The gene pool of human genes has been slowly changing over a period of time. As the great migration started from the African regions, the pool started to move forward. And most of the gene pool tried to remain same. However, over a period of time, certain changes started to happen, leading to occurrence of newer genetic pools. Either this was for good to adapt to the newer geographic territory or requirement at that point of time, or something which was aberrant leading to a set of problems. So these changes, what happens? Dependent on various phenomena. What is commonly known as a bottleneck phenomena is a concept wherein the original population's genes get segregated and only certain set of genes are lost in this transition, or a certain new set of mutations are born, which can be just pointed out to the certain set of individuals or certain set of populations to begin with. This occurrence can occur due to various reasons. One is like a geographical barrier. Only certain set of genes were able to certain set of population moved forward carrying that gene pool, or a mass extinction type of a phenomenon had happened and leading to certain type of genes to be left over. And this is what we call as founder effects. This founder effect can be for good or bad. As we know, as the great human migration started to happen from the African regions, the gene pool started to change when they moved from Africa to Middle East, then to the Europeans or the Asians, South Asians, East Asians, then finally coming into the Americas. So there has been a changes has been happening, and where certain set of genes are limited to certain geographical territories, leading to certain type of beneficial effects in those group of populations, or even leading to some amount of disorders. So when we look into it, how different diseases are common into these type of diseases. So we know that disorders like Tay-Sachs, cystic fibrosis, Gaucher's, familial Mediterranean fever are much more common in the Mediterranean or Ashkenazi Jews especially, or diseases like Stargardt's or sickle cell anemia are much more commoner in African population. So we do know that geographies do decide, and the gene pool in those geographical areas do give us an understanding. This understanding helps us to narrow our differential diagnosis when we see patients, and not only that, how our diagnostic approach or therapeutic approach will happen to this subset of patients as such. So what genetic movement disorders are common in Asia, which can be either due to founder effects, bottleneck phenomena, or other factors. So given that we are talking here about the movement disorders, and we want to know what are the movement disorders, or which genetic movement disorders are common in the Asian regions. And this is what I'm going to talk to you about in the next few minutes. So how to decide which genetic movement disorders were common? It was easy for us if we had a systematic databases of genetic pools of cross populations across the globe, and based upon that we had a clear-cut bibliography of disorders which are exclusively limited based upon the gene pools. However, this is not available. This is the biggest shortcoming, and this shortcoming is mainly because of the financial availability or funding supports, and various other political and geographical changes or requirements of these sections. So what we know is limited. So it was a difficult topic for me to start with. So I decided of late the most common thing what we look is into ChatGPT. I know all of you have heard about ChatGPT. So I thought let me go and search. I may get a right away answers and it may help me to decide what I should speak about. So I went to ChatGPT to ask about, is there any genetic disorders which are exclusive to Asia? The answer was none there. Then I went ahead and asked, are there any genetic disorders which are common in Asia or any genetic disorders which have founder genes in Asia? Yes, here I got some answer from the ChatGPT. Thalassemia, G6PD deficiency, phenylketonuria, Wilson's disease, sickle cell disease, neurofibromatosis. These are the set of the diseases which were there. But is this the only set of disorders which are common in Asia? Or I wanted to look into more specifically from the movement disorders. For movement disorders, we got answers as Huntington disease, dystonia, spinocerebellar ataxia, Wilson disease, and Friedreich's ataxia. Albeit, we may agree to some aspect here. We all know that some of this is very generic in aspect and does not give a specific answer what we are looking for. Even though Huntington's disease is there, I don't think it's as common as in European or the American populations as such. Dystonia per se is a very general terminology. So we wanted much more better answers for this, and that's when we started to work forward. And this is where the societies like the IPMDS and the Asia Oceanic section starts becoming important for us. And the IPMDS has constituted a special task force called as Movement Disorders in Asia Study Group. This Movement Disorders in Asia Study Group has specialists in movement disorders from across the Asian region who work on these diseases. And here we went ahead and did a PubMed screening from 1969 to 2022 to look into keywords such as Parkinson disease, Parkinsonism, ataxia, dystonia, chorea, tremors, myoclonus, movement disorders, CJD with Asians or Asia. In addition to this, we also went back to these experts to ask about, are there any things which you know that is common in your area or in your geographical territories, or do you agree these diseases are common in Asian regions? And based upon this, we have narrowed down on certain set of disorders which we call it as are more common genetic movement disorders in Asia. And these more common genetic movement disorders in Asians include Wilson's disease, spinocerebellar ataxia type 12, 31, 36, Gerstmann-Straussler-Scheinker disease, PLA2G6 related Parkinsonism, adult onset neuronal intranuclear inclusion disease, paroxysmal kinesogenic dyskinesia, X-linked dystonia Parkinsonism, dentatorubral pallidoluysian atrophy, Woodhouse-Sakati syndrome, benign adult familial myoclonic epilepsy, Kufur-Rakab disease, tremulous dystonia, Segawa disease, Part 2, Unner-Tan syndrome, which is described by Professor Unner-Tan in Turkey, and the Dr. Wallis variant, which is described by Professor Wali in India, specific Parkinson disease mutations. It's impossible for me to make any big justice to talk about each one of these diseases in details, and definitely thankful for my previous speaker to cover up certain set of disorders already there. So I am going to cover up the diseases which are there on your left hand side, and I am trying to give a brief over them. I think in this context, at this point of time, I should tell that the first and foremost disorder what we should talk about is Wilson disease. And being in India, talking about Wilson disease is as good as talking to anyone, any neurologist to talking about it. They know much better than me talking anything down here. Wilson disease is well recognized in the Indian setup, and lot of works have gone on Wilson disease especially. this is a point where I should acknowledge some of the pioneers who have worked on Wilson disease in India, especially in the neurology section. I need to specially thank Professor H. Satyanarayan Swami, Professor Arun Talley, and Professor Sanjeev Sinha, who have been pioneers in starting the Wilson disease clinic in 1970s, in mid 1970s, which has commemorated to form one of the apex Wilson disease clinics in globally. In addition, I should specifically also point out Professor Mohit Bhatt in Mumbai, who has been in a great contribution to Wilson disease in India. All these works, the number of patients what we see and the type of works what we have done over the last few decades has led to culminations to get 3 different societies who are directly involved in the care of Wilson disease patients. That is the Movement Disorder Society of India, Indian Society of Pediatric Gastroenterology, Hepatology and Nutrition, and Indian Nutritional Association study. All these societies have come together to form a consensus guidelines on management of Wilson disease in India. And this is what it shows how common it is. As we know by this slide itself, I can tell that all of you know that Wilson disease is a multi-system disorder. It includes symptoms all the way from CNS symptoms in the form of behavioral changes, dystonia, dysarthria, excessive salivations, dysphagia, mask-like faces, chorea, you name a symptom, it is there. Then we have in the eyes the classical Kaiser-Fleischer rings, cardiac involvement, renal tubular dysfunction, arthritis, and the most commonest well-known part of Wilson disease is hepatic symptoms in the form of hepatomegaly, jaundice, acute hepatitis, fulminant hepatic failure, and cirrhosis. And the list keeps on growing as such. Just for a set of people who may not have heard about Wilson disease to begin with, or who may not have seen a patient with Wilson disease, this is a classical video. What you are seeing down is a patient with Wilson disease who is bedbound, completely unable to move around. It's a dictum that any young person or a young child presenting with the extrapyramidal symptom has to be worked up for Wilson disease. And any person with the extrapyramidal symptom with both supratentorial and infratentorial signal changes has to be considered for workup for Wilson disease. Why it is important? The importance is because this is a treatable disorder. The person who is bedbound can be made to
उठ कर आ जाओ, इधर तक आकर वापस जाओ 2 बार
and has a decent
जाओ।
quality of life. This is why it is important. Probably you will not hear about many of the genetic disorders, or there may be very few genetic disorders where you hear about treatment. And Wilson disease is one such disorder where we shouldn't miss it out. So, what is Wilson disease? So, Wilson disease is a genetic disorder which is caused due to mutation in ATP7B and with the autosomal recessive inheritance located in commonly seen in India, China, Korea, Japan and Taiwan. Age at onset is commonly between first and second decade of life, and it has a progressive course leading to death if left untreated. The gene which have been highlighted there, please remember all these purple round films indicate that the gene when it was discovered for that. The Wilson disease gene was discovered in 1993 and potentially these patients are treatable with a good outcomes. Now, coming to the next disorder. It's really an aspect to tell that I'm jumping on this Asia-Oceanic subsection to talk about from Wilson disease to spinocerebellar ataxia, where both of these disorders are significantly common and much more geographically have a hot spots for the disease. Unlike Wilson disease, I should tell that spinocerebellar ataxia is almost exclusive to one community globally, which is the Agarwal community. This Agarwal community is a business community what we see, and they are basically from the origin in the northern India, a place called as Agora. And this business community can be seen across India and across globally. This is a phase where I should specifically remember Professor K.K. Sinha's contribution here for recognition of spinocerebellar ataxia, and not only that, highlighting that SCA belongs to a certain subcommunity. There have been exclusive hotspots where spinocerebellar ataxia type 12 has been looked, especially from Delhi AIIMS, where Dr. Achal Srivastava has been working up, and definitely here Dr. Rishikesh Kumar is working on SCA 12 in Kolkata. We do know that even though the name tells as spinocerebellar ataxia type 12,
20
these
से
patients
उल्टा गिनती
have
कीजिए।
predominant
20,
symptoms in the form of
19,
tremors.
17,
That is
16,
exclusive in the form of particular
14,
action
13,
tremors,
12,
limiting to
11,
upper limb, or it
10,
can be generalized in the form of
9,
head tremors, neck
7,
tremors, or leg tremors. But commonly,
5,
please do
ठीक है,
remember,
दोनों हाथ ऐसा
any
सीधा
person
पकड़िए।
presenting with
ऐसा
tremors
कीजिए दोनों हाथ को।
with the Agarwal as a background, please do workup for spinocerebellar ataxia. They may also have, or down the course, they develop ataxic features
ऐसा
and
पकड़िए।
other cerebellar features. They may also have pyramidal features in the form of hyperreflexia, extensor plantars, and extrapyramidal features.
राइट हैंड से मेरे उंगली को छूने का, नाक को छूने का।
Balance issues. And occasionally eye movement abnormalities may be seen in this subset of.
लेफ्ट हैंड से।
To summarize, to remember that spinocerebellar ataxia type 12 occurs due to the genetic mutations in the it's a polyglutamine repeat disorder occurring in the gene PPP2R2B on the chromosome 5 in the autosomal dominant penetrance. It's almost exclusively limited to the Indian subpopulation, with the age of onset varying from second to sixth decade. Most of the patients have slowly progressive symptoms, with tremors as prominent symptom followed by ataxia. Coming to the next disorder, that is spinocerebellar ataxia 31. This spinocerebellar ataxia 31 is caused by a pentanucleotide repeats in the gene BEAN1 and TK2 on chromosome 16. It's an autosomal dominant disorder which was prominently located or limited to exclusively to Nagano district in Japan. Commonly, most of these patients start to have symptoms in the form of cerebellar ataxia, dysarthria, hyporeflexia beginning around 6th decade of life, which is very slowly progressive over a period of time. These symptoms are primarily managed symptomatically as such. The gene for spinocerebellar ataxia was documented in 2007. Spinocerebellar ataxia 36 is a hexanucleotide repeat disorder, once again common in Japan, and that is also common in the Japan territory of Chogudu near the Asidian river, and hence it is also called as Asidan ataxia. In addition to Japan, SCA36 is also seen in northwestern territory of Spain called as Galicia, and hence also known as by the name Costa de Morte ataxia or coast of death. Common age at onset is around 4th to 6th decade of life and has a very slowly progressive course. Symptoms include, in addition to cerebellar features, people may have lingual atrophy with fasciculation, but very rarely dysphagia. They may also have sensorineural hearing loss. The next disorder is Gerstmann-Straussler-Scheinker disease. This is a prion disorder occurring in due to mutations in PRNP gene, which has an autosomal dominant penetrance. The most commonest is P102L variant seen in Japan and Korea, and in Europeans we commonly see A117V. Most of the time people have onset in the 4th to 5th decade of life with symptoms such as cerebral ataxia, hyporeflexia, cognitive decline and dysesthesias. Based upon the type of symptoms, people tend to have different types of clinical symptoms, mutations. A mutation in Q212R, people present with prominently with cognitive decline without ataxia, whereas P102L present with Parkinsonism and psychiatric features, and mutations in P105L has prominently late onset atax-spastic paraparesis, with the average life expectancy of these patients being around 40 to 50 months. The next disorder which is common in Asians is the PLA2G6 related Parkinsonism, which is of late well recognized, and slowly the number of patients with PLA2G6 is increasing. This PLA2G6 is an autosomal recessive disorder with different mutations seen commonly in China, India and Japan, occurring with the Parkinsonism phenotype occurring in the 4th to 6th decade of life. The common clinical symptoms include Parkinsonism, dystonia and psychiatric features. However, based upon the mutations, people can also have infantile INAD type, infantile neuroaxonal dystrophy or atypical neuroaxonal dystrophy, or patients can also present with a hereditary spastic paraparesis type of a clinical picture. This is a young girl or an adolescent girl who had presented to us with features of Parkinsonism, cognitive changes, which progressed over a course of 2 to 3 years with rapid deterioration over a period of time, with becoming bedbound and dead with poor response to levodopa. So some of these patients may have good response, but most of the patients
ಉಚ್ಚಗಿಚ್ಚೆ ಮಾಡೋದೇನು ಹೇಳಲ್ಲ ಈಗ.
Coming to the other common disorder is adult onset neuronal intranuclear inclusion disease. This disorder is well known since 1960s. However, the gene for this was only documented or discovered in 2019. This occurs due to mutations in Notch2NLC gene causing to GGC repeat expansions, which has an autosomal dominant type of a penetrance. Commonly seen in Japan, China, Taiwan, with the age of onset being to mid to later life. Most people tend to have symptoms of cognitive decline, Parkinsonism, tremors, ataxia and peripheral neuropathy, with the classical features of eosinophilic or ubiquitin positive and P62 positive intranuclear inclusions. Currently, MRI has helped us to give a clinical cues wherein MRI shows high intensity signal changes at gray-white junctions on diffuse weighted images. The treatment is currently symptomatic and usually people tend to have a progressive course leading to death. Finally, to conclude, we know a few well-established genetic disorders are recognized and characterized, and most AOS countries are either underdeveloped or developing countries, leading to limited funding for population-based studies. We do require to have much more standardized library of genes which are seen across the Asiatic regions, and based upon that what type of genetic disorders are known. Yes, some efforts are being done in this direction, like the Genome Asia project, which helps to discover the genes across the Asia, or in the countries when collaborative studies such as the GOPI-YOPD looking into the early onset Parkinson disease genetic works in India, which is happening, or where the efforts are being supported globally, such as from the Global Parkinson's and Genetic Programs, from the Michael J. Fox Foundation, which is trying to help to find out to get everyone on the same plateau. Still, being such a high population, one of the largest continents globally, with a thickly populated population, there are much more diseases and genetic disorders with founder gene effects will be there in the Asian region, which needs to be systematically looked forward. I definitely thank for whole of the movement disorders Asia study group to get this program to go forward, and the Parkinson's Research Alliance of India to make the things happen in Indian aspect of that. Thank you. Thanks a lot.